Assalamu alaikum, Masa al-Khair. Good evening, everybody. My name is Sbeih. I'm a neurosurgeon, and we are transmitting live from Farah Medical Campus here in Amman, Jordan. The backdrop is a view of the city of Jarash, which is full of Roman antiques and amphitheaters, and it is said that it is second only to Rome. In Jarash, we have a festival that's been running for the last 40 years, in July, August every year. This is Jarash, the main street. This is the Jarash festival at night. Again, the street with the columns. And there at the end of the road, there was a station there where you can go to the four corners of the world. This is the main amphitheater where all the festivities take place. And this is the main action theater. So there are about 4 or 5 theaters, but this is the main one where thousands of people would gather to enjoy the evening. This is one of the famous Arab stars. But not only the Arab stars, but everybody from all over the world with every kind of music and songs. And this is just some of the groups that visited Jarash, and they visit every year. So back to our theme for tonight is the Abducent Nerve Schwannoma from the clinical, radiological, operative, and pathological point of view. Just looking at the anatomy, and I always maintain that we have to remember those people who taught us anatomy, who created a new vision on the anatomy of the nervous system. And the first and foremost is Albert Roten, late Albert Roten from Gainesville, Florida. He really changed our concept of microneurosurgery. Professor Majid Sami from Hanover, Germany, again, another man who changed the philosophy of the surgery in the posterior fossa. Sam al-Mifti, Syrian, living in States in Harvard, a great man, a great pillar of skull-based surgery with his book, Al-Mifti Meningiomas. And this man from Slovenia, Professor Dolenz, who back in 1983, he invented the Dolenz approach for the cavernous sinus. Everybody laughed at him. They say he's crazy. In 86, everybody recognized him. And 20 years later, in 2006, he made this conference, called it Cavernous Sinus, 20 years later. And I was one of the invitees there, really looking at the cavernous sinus from a different point of view. He wrote 4 books all about cavernous sinus. He is a friend of us, friend of Jordan. He helped us creating the cadaveric lab here in Jordan, and here in one of our tours at downtown Amman, having the usual Turkish bath. Ali Kresht is Lebanese in Little Rock, Arkansas, is again one of the great pillars of skull-based surgery in the world, and he also visited us, helped us in the many courses we had. Professor Takeshi Kawase, who invented the Kawase approach, and Professor Liliam Shaker from Seattle, United States. All these people are very important to remember. So back to the abducent nerve anatomy, and just overview of the abducent nerve. Follow the yellow line. This is, of course, midbrain, pons, medulla. The abducent nerve comes from the junction between the pons and the medulla, from the pontomedullary sulcus. It goes up like this. This is called cisternal part, because it is in the prepontine cistern. Here it goes into the clivus, the so-called Roller's canal. Here it goes in the lateral wall of the cavernous sinus, and here it goes into the superior orbital fissure and into the orbit. So we're talking about the cisternal part, the Roller's canal, cavernous sinus part, superior orbital fissure part, and the intraconal. So this is the overview of the anatomy of the abducent nerves: sternal, the venous and the Rullis canal, the cavernous, severe orbital fissure, and the orbital. So this is general overview. This is the sternal part. We got into the Rullis canal, we got into the lateral wall of the cavernous sinus, into the severe orbital fissure, and then into the orbit. Here, at the junction between the clivus and the vitreous bone, in this fissure here, we have here the indentation for the trigeminal nerve, and the nerve goes into the sulcus there. So overview into the skull base, middle and posterior skull base. This is foramen lacerum, foramen spinosum, foramen ovale, and the suture between the clivus and the vitreous bone, and the impression for the trigeminal nerve. Just medial to it would be the abducent. There is a funny thing about the anatomy of the sixth nerve and seventh nerve. This is cut section of the medulla, pons and medulla junction. This is the facial nerve nucleus. For some reason, the facial nerve should come here. For some reason, it goes backwards, rotates around the nucleus of the abducent, and then come forward. Why? It's called chemotactic theory. We don't need to indulge in that, but this would cause a hump in the floor of the fourth ventricle, and this is called facial colliculus. Of course, this is wrong terminology because it is not the facial here. This is the abducent nerve, but the fibers are rotating around it. So again, here looking at the abducent, this is the abducent. The facial, for its own reasons, goes backwards and then comes back. And this would create this hump, which when you look here, you say this is facial colliculus. So as the abducent nerve comes out, it comes from the front. In the sulcus between the pons and the medulla, and the frontomedullary sulcus, the distance between the two nerves is just about 1 to 1.5 centimeters. And then from there it goes up, anterior and lateral. Again here, both vertebrals, basilar, the abducent nerve goes up like this. This is cadaveric specimen, this is the basilar, and this is the abducent coming up. This is a frontal view. Overall view, both vertebrals meet to form the basilar, and here is the clavicranial nerves. This is the accessory nerve, the jugular foramen, the facial vestibular complex, the trigeminal, and then just medial here is the abducent going up. Again, to show you that it goes up, really from down direction up, from caudal to cranial, and it goes here into the Rullis canal. So we're back at the clivus here. This is the trigeminal, and these are the two nerves as they come up. They go into the Rullis canal. If we take the dura out, we will see lots of the venous sinuses. This is called basal venous sinus. This is the inferior petrosal sinus. This is superior petrosal sinus. This is the trigeminal. Medial to it, about 6 millimeter, is the abducent going into the Rullis canal. So this is the nerve going into this venous, what we call venous gulf. Underneath this ligament, which is called vitreous ligament, vitreous ligament, or Gruber's ligament, and then it goes into the lateral wall of the cavernous sinus, into the severe orbital fissure. Again, to show the upward course of the abducent coming from the pontomedullary junction, going up. Here it goes underneath the Gruber's ligament and goes into the lateral wall of the cavernous sinus. This is a very beautiful paper published by Tufts in 2012 in the World of Neurosurgery, and it shows this nerve going into the underneath the Gruber's ligament there. And this beautiful paper also by Magitsani and Paolo Cavabianca, just concentrating on the abducent nerve and the Gruber's ligament. Here we are on the left side. This is the trigeminal ganglion, trigeminal nerves. This is the Gruber's ligament. If you take the trigeminal off, you will see the carotid and the Gruber's ligament. And if you remove the Gruber's ligament, you will see the Rullis canal. So Gruber's, Gardaningo, and Rillo, and Vail, famous names for the anatomy of the abducent nerve. And again, this beautiful paper reminded us of the value of this discovery, value of Gruber, who discovered the ligament, value of Rillo, who discovered the canal, value of Vail, who publicized the word the Rillo's canal, and Gardaningo, who discovered the sixth nerve palsy secondary to otitis media and mastoiditis. Again, the anatomy again. This is published also by Majid Sami in Germany, saying that it could be duplicated. The abducent nerve could be duplicated. Two nerves going into two entries into the Rillo's canal. And to my surprise, when I looked into the literature, I found up to 28% of the anatomy speaks about the unilateral duplication of the abducent. And it is duplicated in bilateral, but both sides in 1 to 2%. This is anatomical studies. So back to, again, where the abducent comes from here into the Rillo's canal and the lateral wall of the cavernous sinus, then into the orbit to supply the lateral rectus. This is the radiology of it. This is the Rillo's canal. This is the cavernous sinus part going into superior orbital fissure and then into the orbit. Again, you can appreciate this. Abducent nerve on the left is going this side. You can see this. Now, usually in T2, you can see the nerves, but you need to do something called fiesta sequence to see the full length of the nerve. Once we are in the cavernous sinus, this is cut section of the cavernous sinus. Cavernous sinus on this side and the other side, this is carotid, this is carotid. The nerve lateral to the carotid is the abducent nerve. This is the third nerve, this is fourth nerve, this is V1. And the cavernous sinus stops at the upper level of V2, which is the maxillary. This is a picture from the book of Dollins of the left cavernous sinus, V3, trigeminal, third part V3, V2, and V1. And this is the oculomotor, this is the trochlear. Here is the triangles of the cavernous sinus, and if you open this triangle, then you will find the carotid, and lateral to it you will find the abducent nerve. This is the anatomy that we learned from those giants. Again, we are looking on the left side. This is the left cavernous sinus. So this is the venous lakes. And we are pulling the V1 down so that we can see the cavernous sinus. And we discover the glory and the what should I say, it's the something magic about the cavernous sinus triangles, which was described by Dollins. We have 10 triangles, which I, as a scalpel surgeon, I know by heart. What to find in every triangle, because there's no more no man's land. We can go there and operate there. So this is a beautiful view of the lateral wall of the left cavernous sinus. This is the carotid cavernous part, and this is the sixth nerve going into the severe orbital fissure. For our residents here, this is the inferior lateral trunk, giving arteries to the foramen ovale and foramen rotundum, and this is the meningoepiphyseal trunk, giving the dorsal meningeal artery, the artery of the tentorium, and the inferior hypophyseal artery. People, when they ask them the exams, they would mention this to you because there is something called the Greenberg book, but they have no idea about these arteries. So reading from Greenberg book is not good at all. It will not teach you anything. Once we are in the orbit, this is again the left orbit, and then we will see that this is the lateral rectus, inferior rectus, superior rectus. The nerve comes medial to the lateral rectus, like this. Here is the lateral rectus, and this is the nerve. So it comes here from the cavernous sinus, severe orbital fissure, and then goes in. When it goes into the severe orbital fissure, it goes inside the annulus of Zen. So every structure is inside the annulus of Zen except two structures, the frontal branch and the kinesiocellary branch and the severe ophthalmic vein. So this is to supply the lateral rectus, and you can see again, this is the anatomy of the orbit, which as a neurosurgeon should be mastered. So what happens to the abducent? It can get injured, it can get diseased, it can get affected by so many pathological factors, tumors, trauma, infections, vascular, and vascular here means aneurysm, and also here means hypertension, strokes, they can affect the nerve. Medical causes like so many, like also diabetes and multiple sclerosis, and we have the idiopathic cause. So it can be affected by so many diseases. And if you don't remember the anatomy of the abducent, you cannot reach the diagnosis. So let's go to the tumors of the abducent nerve. So our topic for today is the schwannoma. The name is schwannoma. The older names are neuronomas or neurodemomas, just the same. All cranial nerves except olfactory and optic nerves are potential risk for schwannomas. So you don't see schwannomas in olfactory nerve or optic nerves because there is no myelin sheath, there is no Schwann cell, so to give you the schwannomas. So they are derived from Schwann cells. They constitute about 7% of the intracranial nucleus, and they are common in females, which is lucky for us males. It could be solitary schwannoma, it could be multiple schwannomas called schwannomatosis, or it could be with other tumors, and in this case constitute the neurofibromatosis type 2 and von Recklinghausen. So most of the schwannomas arise from sensory nerves. As we said, the commonest is the vestibular schwannoma or trigeminal schwannoma. These are major sensory nerves, but it can also affect the motor nerves, but this is very rare. So the commonest schwannoma ever in your head or in your body is the vestibular schwannoma. And then the others come. Trigeminal comes next, trigeminal schwannoma, after the acoustic. Lower cranial nerves, facial schwannoma, and the three are the least. So these three are the least cranial nerves affected by schwannomas. And our topic today is about this, abducent nerve schwannoma. So to see these, and we have to popularize this technique called Fiesta. Fiesta means fast imaging employing steady state acquisition. I don't remember this details, I remember Fiesta. But you can see the nerves, this is the trigeminal and this is the abducent. Here you can see the nerves in the intermediate meatus. Here you can see the abducent. Here you can see the, again, intermediate meatus with the Fiesta. Here you can see the nerves going into the jugular foramen. And here you can see the hypocrystal, which is the most difficult to see. So schwannomas, cranial nerve schwannomas are rare. In fact, they are very rare. Look at this. The first report about this important topic was just a few years back, 1981. Recent. These two people, Tang and Sbeih, they classified this. Tang classified it into type 1, meaning that the schwannoma is within the cavernous sinus. Type 2, it is in the cistern. This man added a new type. He said it is not either in the cavernous sinus nor in the prepontine. It is in between, so he called it dumbbell-shaped. So we have three types. Looking into literature, only 30 cases of abducent schwannoma has been reported, and our case would be 31. This is very rare. 5 in the orbit, 5 in the cavernous sinus, and the 20 in the cistern. So we are one of 20 abducent nerve schwannoma in the cisternal part of the nerve. And look at this statistics. Total resection was achieved only in less than 50%. And function recovered in only 7 cases, functions of the abducent. And this is the homework. This is the list of the cases published of abducent nerve schwannoma, the year publication, the author, etc. So cisternal means in the cistern, in the posterior fossa. Look at this. How would you tell this is abducent? You can't. Most of the cases you can't preoperatively. You decide, postoperatively, you decide by histology that this is schwannoma, and then you say, well, it was attached to the abducent, so it is abducent nerve schwannoma. But this could be confused with so many diagnoses. Some of the publications about the cisternal part, look at this. This is mimicking intrinsic brainstem. So you may have something like this and say, oh, this is intrinsic brainstem. It is hopeless. Let him go and die in peace. No, this is schwannoma that can be removed and it is benign. Abducent nerve schwannoma case report. It can attain large size, and you can think here because they are in large size, they are near the internal detonatus. So you may think this is a schwannoma, vestibular schwannoma. Again here, large size schwannoma. This is recent publication this year in February 2019, and I know this because I'm one of the editorial board of the World of Neurosurgery. It can be cystic, like this. So you say, oh, this is arachnoid cyst or epidermoid cyst. While if you do this, you know that this is a cystic schwannoma. Again here, this small schwannoma with review of literature from China, from UK, from Hull. Hull is in north of England. You can see this tumor. From Canada, again, cellular schwannoma. Dr. Abducent will tell you that we have the regular schwannoma, classical one, and there is the cellular one. But look at the surgery here. They have left this. So this tumor, it is difficult surgery, no doubt about that. That's why we said 50% were totally excised. It could be within the cavernous sinus, 91 from USA, from California, Los Angeles, this cavernous type of abducent. Again, another paper from Turkey and Japan. And this case from Portugal with the cavernous sinus abducent nerve schwannoma. Intracavernous from Australia. Or it could be in the cisternal part and the cavernous part, like this. So most of the time you would diagnose this as a trigeminal schwannoma. It's not. This is a dumbbell abducent nerve schwannoma. Or like this is dumbbell. This is the angiogram showing the tentorial artery being embolized from India. Or it could be in the orbital, and these are the papers, 5 cases only in the orbit. These are the cases and the authors. So this is intraorbital, completely intraorbital. Again, this case from Japan, intraorbital. From India, intraorbital. From Portugal, intraorbital. The commonest tumor in the orbit, of course, is the cavernoma. Here is also another intraorbit. So what is the management of these abducent nerve schwannoma? Either you do surgery or you do radiation, which I prefer, of course. The upfront for me is surgery. From the point of view of cytotoxic relationships, from the point of view of real cure for the patient for any tumor, it is surgery first, surgery second, surgery 99. The 100 number option is the radiation. How do you reach to the abducent schwannomas? According to where it is. Is it in the orbit or in the cavernous sinus or in the posterior fossa? So you can reach various ways into that part. And you have to master all these. If you just know one approach, you will be dead. Radiation treatment, what is called stereotactic radiosurgery. Again, I hate the word radiosurgery. I don't know why it was invented. It is just to give the impression that the man doing it is a surgeon. He is not. He is a radiotherapist. He just pushes buttons. Or you can call it linear accelerator radiosurgery, different kinds of radiosurgery, or fractionated stereotactic radiotherapy. Let's look at some of these cases. From India, this gamma knife radiosurgery case, look at this. This is the tumor, and this is 7 months. This is poor paper. It's only 7 months follow-up. How do you know that it is not recurred, it did not regrow, etc.? So it is not a good paper to publish at all. And this case, gamma knife, 4 cases. This is from where? This is from Russia. They're showing you the tumor being treated. Look at this. The tumor is still there. And they speak about tumor control in 95% of cases. For me, I cannot accept, I cannot prescribe to such lesions treatment. Some of the cases that has been treated with the gamma knife, only few. And most interesting, always the follow-up is very short. Look at this, tumor, surgery, then partial resection, and then giving the rest a gamma knife. Again, this is not good. This notion of going into large tumors and then taking part of it and then giving the rest radiation is not good. It is not healthy. It is not acceptable. It just shows that you are not a good neurosurgeon. And this is for radiosurgery for trochlear and abducent nerves. And again here for the non-vestibular schwannomas, gamma knife. So I promised to finish within 1 hour, so I'm going to do that hopefully tonight. This is our case, Abducent Nerve Schwannoma, from the clinical, radiological, operative, and pathological correlation. We know what is the abducent nerve, we know what is the schwannomas, so let's look at this case. This is the case I'm going to present today. A huge stereofossa tumor, CT scan, and the MRA. 39-year-old Jordanian lady living in Emirates or Qatar, somewhere in the Gulf. Notice that female, we said that females are commonly affected. For 2 years, she had occipital headaches. What was the diagnosis? Tension headache, desk. This is what we think in this part and in the underdeveloped world. Headache, this is tension. This is this is desk. So oversimplification of things, oversimplification of medical knowledge, and it is disastrous, to say the least. And then for last 2 months before presentation, she had numbness in her left face, in her left side of the tongue. Again, many doctors would think numbness in the left side of the tongue is crazy. هذه المريضة عندها خضران في نص لسانها. She is crazy. This is stress. No, of course, the trigeminal nerve can be affected, and half of your tongue can be affected. And then she had tinnitus, and then she had dizziness, and then she had dysphagia. And the most important one, and the difficult ones, for liquids, dysphagia for liquids. Not only dysphagia for solids, but dysphagia for liquids is dangerous because this would lead to that water would go into your lungs. Recurrent coughs, ضلت كحكة كتير. هي بتاكل من جنبها كوباية مي مشان تضل تشرب. Voice changes, hoarseness of voice. Vital signs were okay. General examination was normal. Glasgow Coma scale was 15/15. In spite of all this, the Glasgow Coma scale 15. Again, Glasgow Coma scale is not everything. Doesn't mean that this is okay. 15/15 is for the level of consciousness. The hand movements, the arms, the eyes, and the responses. So don't be misled by saying, "Oh, Glasgow Coma scale is good. That patient is good." He may be hemiplegic and blind, for that matter. She had left sixth palsy. She had decreased sensation in the left side of the face, and she had left facial palsy. And when the three comes together, the only place you can catch them is the brainstem. So this is the lady. Optic nerve, her pupils were reactive bilaterally, and there was nothing in the visual field examination, but she had pyramidal weakness 4/5 on the right side with brisk reflexes. So here we are just to show you that some of what we call arm drift. Raise their hands like this, and one arm will go down. If I'm closing my eyes, my arm will go down. This is called pronation drift, and it is the early sign of weakness. And we keep telling nurses, you can do Glasgow Coma scale within 1 minute. ارفع ايديك، حرك رجليك، انت وين يا عمو الى اخره، فتح عينيك، رد علي، خلاص Glasgow Coma scale is done. It's easy. So she had weakness in the right side of 4/5. CBC, kidney functions, electrolytes, liver functions were normal. Urine analysis showed some UTI there. The image, look at this. This is T1 without contrast. You can see the deformity of the fourth ventricle. It is in the cerebellopontine angle, but look at the pressure on the brainstem. This is T1 without contrast. This is T1 with contrast. You can appreciate the pressure on the brainstem. Cystic changes inside. Here we are close to the jugular foramen. Here we are close to the intermediate meatus, and here we are at the back of the clivus. That's how we got the three nerves. Here we are going actually to the mesencephalic system and above. This is T2, so these nerves are affected here. Trigeminal is affected, sixth nerve is affected. Coronary view, look how much left of the brainstem is totally compressed. Here, the edema in the brainstem. This lady should have been dead with this lesion, but because it is slowly growing, that's how she survived. It is slowly growing tumor. Again, we are in the pre-pontine system, compressing the brainstem edema. Again, a bad prognostic sign. CT showing what looks like a cystic lesion. It is not. Here we do the intermediate meatus. We used to see whether the intermediate meatus is widened. If it is not widened, most likely it is not vestibular, but this is not a rule. So you can see that both internal meati are okay. Here you can see the vertebral is pushed from left to right. Basilar is pushed to the side, and I will show you the basilar during surgery. This is important. You need to see that there is no occipital sinus. You need to know what exactly is going there. You need to see the superior orbitus, the superior petrosal sinus. You need to see vein of Labey, because you don't know which approach you are going to use. So differential diagnosis for this case. Schwannomas. They are commonest lesions in the cerebellopontine angle. And the commonest, of course, is the vestibular, but there are others, non-vestibular schwannomas, oculomotor, trochlear. Remember that we said optic nerve and olfactory nerve, they don't have schwannomas. Others, they have oculomotor, fourth, fifth, sixth, seventh facial nerve. This is one of my cases I present to you in the coming weeks. Schwannoma, again, one of my cases, jugular foramen schwannoma. And how would you know that this is a jugular? Because it is attached to one of the nerves in the jugular foramen, be it the glossopharyngeal or vagus or the accessory. I have accessory nerve schwannomas, and I have hypoglossal nerve schwannomas. Glioma is going to the CP angle, epidermoids, chondrosarcoma, chondroma, giant cell tumor of the bone, endolymphatic cyst in this patient of mine from Sudan. Hemangioblastoma going into this angle here. Glomus, large cell medulloblastoma, metastasis, and exactly in where the trigeminal nerve is. We say, oh, is it very rare? It can happen anywhere. We have metastasis inside the posterior lobe of the pituitary. And choroid plexus papilloma, lymphoma, ependymoma, atypical ATRT, and arachnoid cyst, DNET, PNET, aneurysm, histiocytosis, cholesterol granuloma, petroclival meningioma, papilloma, lipoma, lymphoma. If you keep this differential diagnosis in your heart and mind, then you cannot commit mistakes. Alan.
Thank you, Dr. Ibrahim. So, what is an oncologist doing in a CP angle session where we almost know what is going on here? It's this differential diagnosis is really what it's all about. Despite the fact that you really expect schwannomas to be on this, and the crime of sending these patients to radiotherapy without knowing what this is. These are actual cases where you could have easily missed a glioma that should have been treated with surgery to be followed by radio with an alkylator. It could have been an epidermoid. It could have been a chondrosarcoma that the mainstay would have been the surgery, because radiotherapy and chemo really do not work. We really subject them to radiotherapy after that, but chemotherapy has very little role to play. large cell medulloblastoma can happen in this area, and the treatment is radically different because after the optimal excision or complete excision whenever possible, they should undergo craniospinal radiotherapy with a platinum-based chemotherapy. I cannot emphasize the importance of not missing a MET because nobody bothered to examine a patient properly and could have spared them the surgery because there was an undetected breast mass, etc. And lymphoma does happen in this area, and it could have been easily missed as such. And in this location, it would have been either a primary CNS lymphoma or a manifestation of a systemic lymphoma with secondary CNS. These patients' treatment is basically methotrexate in high doses to delay radiotherapy as much as possible, and radiotherapy is used as salvage. Histiocytosis can happen in this place, as can meningioma. And I cannot emphasize enough that these are actual cases. This is not a mental masturbation exercise. These are actual cases. And I can't condemn enough the practice of subjecting these patients to radiotherapy or whatever modality of treatment without actually knowing what this is. These patients, when they die, it could have been claimed, oh, they have brain tumor and it's progressed, and everything possible could have been done. We continue having this every week, and these mistakes continue to happen every day.
Absolutely. It is not a mental exercise. It is not exercise of supremacy over you. It is actual cases. We see them, and we should be aware of the differential diagnosis of lesions in every part of the body. Consultations. We asked Dr. Nabil Alouch to come over today. He is not hematologist. He saw the patient because there was history of anemia. Her hemoglobin, iron, and TIBC are within normal. She had low vitamin B12, so just treat her with B12. Dr. Khalid Al-Assad is around, a chest physician, because she had cough. He said, okay, her cough is due to liquid dysphagia, nothing wrong with her lungs. So she had normal spirometry. Dr. Muhammad Al-Assad is around. Do you want to comment, Mahmoud? Dr. Muhammad Al-Assad, ENT, saw the patient because, as we said, she had difficulty swallowing, and he saw the patient for that.
Usually when there is posterior fossa tumor, we usually look for the last 4 cranial hairs. And I find that all of them are normal, and we do nasopharyngoscopy. We look at the mobility of the vocal cords, and we try to also to exclude any paresis of the vocal cord, not just paralysis. And it's about audiology, I think. Yeah, that's okay. Normal audiological, normal middle ear, and everything was normal. Thank you.
Anesthesia was announced fit for surgery in the sitting position, but class 4, which is the dangerous class. This is the American Society of Anesthesia classification, class 1, class 2, 3, 4, and 5. So we do it in the sitting position. As I said, we are one of the centers around the world, few centers around the world who are doing this sitting position, and we are masters of this technique. So if you do the patient supine, you cannot reach that area. You have to flex his or her neck. And to do that, you have to sit the patient so that you can reach to the foramen magnum. So you go in the sitting position, you can use navigation. And we have 2 companies that give us the navigation. Are they around here today? Yes, they are. Mr. Ziad Saleh and Sayyid Nasib, they offer us the help with this navigation, which is helpful, and it is good for teaching. I do not need navigation. As a practiced, experienced neurosurgeon, I do not need navigation. If I need it, then I'm bad. But it's good to say to the resident, where would you put the lesion? Where would you see the lesion? Show me. And then you put the navigation like this to prove him right or wrong. We do it in the under the microscope items and under the cranial nerves monitors. We monitor cranial nerves on both sides, on the side that we need to operate upon. Where to open depends on which area you want. Here you want to reach to the lower cranial nerves, glossopharyngeal vagus accessory, Here is when you want to reach to the 7th and 8th, and here if you want to reach to the trigeminal. Each has its own neurovascular complex relationship, which any neurosurgical resident should know. But do they know? The answer is big, sad no. This is the consent, detailed consent, and Dr. Ma'moon Al-Hadidi is here to tell you that مساءلة الطبية and medical responsibility is that. مؤمن
اولا هي مش مساءله، هي مسؤوليه. دائما any claims against doctors will be looked at from 3 dimensions: diagnosis, management and follow up. اذا كان diagnosis غلط هيطلع المانجمنت غلط، وبالتالي انا يعني بتمنى دكتور ابراهيم هو ماستر في الموضوع تبعه انه كل النيوروسيرجنز يتفقوا على شيء، والا راح تضيعوا الناس اللي عم يعطوا راي. بالتالي الكونسنسس اوف your subspecialty is needed كثير بشكل كثير ضروري. الكونسنت هون من القلائل في المنطقة اللي بيكتب الكونسنت بطريقة رائعة دكتور إبراهيم، كل شيء واضح وكل شيء متوقع مكتوب، وأيضا عند الخروج بياخذ تقرير مكتوب كل شيء واضح. هذا كله مهم، ويمكن حدا لكم ما بيعفيش من المسؤولية. لا، إذا المريض حكيت له كان دايجنوزز صح والمانجمنت صح والفولو اب صح، يعني هذا المسؤولية صارت كلها مدنية متعوضات. فأعتقد إنه يعني مهم جدا الفولو اب. شكرا.
لماذا كتب العمل بالإنجليزية؟
احنا بالعربي هي تهدف الى استئصال ورم في قناة الجمجمة بالعربي and then we'll write it in English. So both, just in case.
إذا واحد عنده مش واضح المصطلح بالعربي
يكون واضح. If the patient is British, for example, it will be written all in English. If he is French, we'll write it in French, and so on and so on.
في لها كود بالعربي نفس الكود بالانجليزي؟ الكود
لا, different.
الكود بالانجليزي.
Of course. Let's see the surgery. So patient is sitting, and we know it is in front of the nerve. So this is the trigeminal nerve. This is the facial nerve. I'm coming from the back, sitting position. Remember, this is the right side here. This is the left side here. Midline is here. I'm retracting the cerebellum. I am working between the nerves. So this is, I notice the sixth nerve attached to the capsule of the tumor. Again, between the trigeminal and the facial, between the trigeminal and the 10, between the facial and the lower cranial. So you work in compartments. Here we are separating it from the basilar. We can see the basilar there. Because the abducent is coming this way. So removal in pieces, not in one piece, never in one piece, piecemeal. There's no place for finger dissection of the tumor. And again, here they are working between nerves. So not only you can damage the nerves by touching them, you can damage them by affecting their blood supply and by pressure, by manipulation. Here we are using the ultrasonic aspirator. This, if it comes to the nerve, it will just suck it. It does not recognize tumor from nerve. It will suck anything you put it on. So trigeminal, facial, the tubercle on top of the internal determinatus, the lower cranial nerves are there. Again, you debulk from within and you then go around. So you debulk, you dissect, you debulk, dissect until you reach. Here is again the trigeminal. This is the basilar, you can see. And I'm trying to take the arachnoid with the tumor, which is a good policy to preserve the blood supply of the nerve. This is the nerve. It's coming this way. So I'm working here. I did not have success. I go to another compartment. Don't persist in one compartment. Move between compartments. Maybe you will get lucky and then it will open up. And I was make the point that this is the nerve, and I'm separating the nerve from the capsule of the tumor. So to me, it is not attached to the fascia, it is not attached to the trigeminal, it is attached to the abducent. So this is abducent nerve schwannoma. Here is the art is to try to preserve the nerve, at the same time try to remove it completely. Remember that 50 of the cases, 20 cases reported in literature did not have complete excision. We were lucky we could achieve radical total excision. But this manipulation will come at a price. This is a very tiny nerve. It can be affected by increased intracranial pressure or low cranial pressure. Here you are really manipulating and removing and etc. So most of the time, this comes at a price.
Let's cut.
No, we don't cut. So this is a band of arachnoid. So I'm trying to cut using my left hand. So I keep telling my resident, you have to be ambidextrous. You cannot say I'm right-handed surgeon. You have to be both-hand surgeon. In neurosurgery, you have to be ambidextrous. I really cut my face many times trying to teach myself how to use my left hand during shaving. I did that. So this is the abduced. I'm taking it off the tumor. Arachnoid. Always take the arachnoid towards the normal tissue and away from the tumor. So this is the band of arachnoid. Again, I have to make sure, and then I would cut it. Here, usually your heart stops because of, is this a nerve or what? So really working between nerves, basilar artery, brainstem. You are in a dangerous zone. It's nerve-wracking and heart-breaking kind of surgery. But the reward is very good. So I'm using this patty with patty to sort of remove the arachnoid. This is the tumor. This is the nerve, trigeminal facial. I'm taking the arachnoid towards, this is the nerve here. Here it is, the it. So I'm going to take it towards the brainstem. So debulk, dissect all the time. Ultrasonic aspirator. Still there is a piece of the tumor there. You don't want to just to take part of the tumor out. You want to take it completely out because this is the only chance the patient has. The trend in the Arab world, in the developed countries, is to take a biopsy and send for radiotherapy, which is a crime. Look at this, I'm tracting on the facial nerve, so this may cause facial nerve. And the abducent can cause damage and the trigeminal also. But everything has to be well-timed and well-calculated. How much pressure you put, and so on. Again, piece by piece, whatever time it takes, I'm not even aware of the time. It is not, again, I repeat it loudly for our international audience, it is not a place for Speedy Gonzalez. There's no Speedy Gonzalez in neurosurgery. Speedy Gonzalez should go to the forest with monkeys. So here you are, all the nerves are there. This is facial, this is trigeminal, basilar is there, abducent is there. This is basilar. This is the dorsum celli, there. Cerviclinoid process. So these are the lower cranial nerves, accessory, vagus, and grossopharyngeal. Grossopharyngeal is usually one branch, vagus is usually multiple branches, and accessory is one branch. So here you are. You remove the tumor completely, preserve the nerves, and to give the patient the best chance possible. Histopathology, Farsa.
This case was schwannoma. You can see typical schwannoma architecture. You can see this is low power spindle cells. They go in one place, intersecting with other places, and there are blood vessels in between them. Yeah. You can see this is typical. You can see areas where are hypocellular in some areas and hypercellular in other areas. I will show you more. But typically you can see hyalinization around the blood vessels, and this is typical of schwannomas. You can see this is typical Antonis B and Antonis A near each other. Antonis A where it is cellular, and Antonis B where it is hypocellular, and you can see some hemosiderin deposition. When you see something like this with spindly cells, this is typical of schwannoma and hyaline blood vessels. Next slide. You can see here, this is our blood vessels, and this is more of Antoni A. You can see some hyperchromatic nuclei. This for beginners may be alarming, but the schwannomas typically they have hyperchromasia. So this is not alarming because this indicates an ancient changes. And this schwannoma has been there for many years. That's why the cells will degenerate and become hyperchromatic, mimicking bad cells or malignant cells. Next slide. You can see here typical of Antoni A and Antoni B areas interchanging with each others with the blood vessels in between. Next slide. Here again you can see Antoni B areas and Antoni A. Spindle cells, most of them they are really bland, not bad. There is no single mitosis I could see. And here you can see typical hyalinization around blood vessels. This is usually typical of schwannomas. When you see hyalinized blood vessels, indicate also a part of ancient changes. Next slide. Typical schwannoma are S100 positive. It's a nuclear and cytoplasmic staining. You can see the nucleus are stained, and it's in the context of histopathology. Typical histopathology is very, very useful to tell you that this is schwannoma and not, for example, meningioma, which is the differential in these cases. Next slide. Bimentin was positive. Bimentin is positive in schwannoma and in meningioma, but S100 is negative in meningioma. So this tells you that this is schwannoma, not meningioma. Next slide. Epithelial membrane antigen is completely negative, and this is again tells you that this is not meningioma, this is schwannoma. So we used the double things. And K67 usually is very low. This was 1%, indicating usually this is a low grade or benign process. So this was called schwannoma, and there was no malignancy.
Thank you. Just for the residents in the room, Antoni A and Antoni B are important. They are in the schwannomas everywhere, whether it is vestibular or others. Antoni A is dense cellular, Antoni B is less dense. And this is a common question in the neurosurgical board exam. So she recovered well on the table, as I always say, and maintain to say that patients should not leave the theater unless they are awake. No patient should leave on a ventilator for the silly excuse that we want to rest the patient. Oh, it is long surgery, 10 hours, so let him rest till tomorrow morning. You are saying this because you have done something bad to the patient and you don't want anybody to know it. Wake the patient up, make sure that there is no problem. Post-op MRI the following day. Don't listen to the ridiculous things that we only use CT to see blood. So we do post-operative CT. No, MRI is superior to CT to show you the hematoma. So stop the nonsense. Stop doing CT after surgery. Do MRI. Let everybody know. Let the patient know. Let the relatives know. Let the residents know whether you have done a good job or not. The very following day. This is it. Brainstem relieved. Trigeminal nerve relieved. No ischemic changes at all. This is with contrast. And of course, where you operate, you will find some contrast enhancement. This is normal. This is very following day, which is something like 10 hours post-operative. This is the edema that was present pre-operative. So, as I said, everything comes at a price. There was no change in the left septal nerve palsy. In fact, it was more pronounced. Left facial palsy was the same. So that's what we'd expect, that the preoperative deficit would remain. She had no weakness. This is post-op. She has sixth nerve palsy as pre-op. So as a lady, she was frightened. She thought her husband was going to leave her because he was not going to see her as beautiful as before. So she was really crying. And I assured her, I have preserved your nerve. It will come back in 3 months' time. Are you sure, doctor? I hope so. God will that it will. So this, yes, sometimes they go and do the squint surgery prematurely for no good reason. This is the discharge summary that Dr. Mohammed Hadid told you about. That needs to be detailed, saying everything that you have done to the patient. Again, this is not my discharge summary. This is the discharge summary from the Atkinson Morley Hospital in London, where I was trained. We were trained to do this discharge summary. So I'm just carrying it back to Jordan to benefit my people. And don't say that it is taking time. It's nonsense. It will not take time if it is done at the time of admission. Discharge summary is done at the time of admission. History, the investigations, and then you write the operative note, and then you write the medications and so on. Coming back to my clinic for follow-up about a month later, still there is some facial weakness. Sixth nerve is still there. Oh, my husband is going to leave me, and so on. Again, reassuring her, with God's will, we have preserved the nerve that your function will come back. 3 months later, again, MRI showing no recurrence, no recurrence whatsoever, and sixth nerve recovered completely. This is one of very few cases in literature where the abducent nerve function has recovered, and this gives value to our case that it was done. 2 years later, the idea that you do the surgery and leave the patient to go home is nonsense. You have to follow them. And if they don't come to my clinic, we phone them. My secretary, Ahmed and Muhammad, they phone patients. Oh, we have not seen you. You should have been there. Why didn't you come? Come over. I don't have money. We can collect. We can help you. Come back. We need to see you. We need to do an MRI. So 2 years later, she came back from Dubai, and we did the MRI. No recurrence, no complications, nothing. 5 years later, no recurrence. And look at these stages. This is when she came with slight abducent. This is immediate post-op. This is about a month of post-op. This is 3 months. And this is the follow-up. Everything has to be documented. And if you learn to document your cases, it would be part of you. I have started documenting my cases since 1978. I have a document of every patient I touched or every X-ray I've got across. So try to do that. Again, this is a teamwork, and I have to thank everybody because this is not my work. It is the work of everybody, especially the administration, providing us with this beautiful hospital that is well equipped with everything, single thing you can think of. The anesthesia, the lab, my secretary, the doctors, the nurses, and my assistant, Dr. Nisa and Dr. Mahmoud Al-Khatib. Again, Mahmoud, you did not provide us with a picture. So I thank you.
تعليق بسيط بس. في مصطلحات بسيطة لكنها مهمة من وحي اللي حكيته. في بنحكي خطأ، بنحكي مضاعفة، بنحكي إهمال، بنحكي تقصير، بنحكي قلة احتراز. يعني من ضمن ملاحظة إهمال إنه بيحكي الدكتور إبراهيم لازم أصحيها. إذا ما صحاها أو ما صورها ثاني يوم هذا قد يكون إهمال. إذا ما حكى لها ترجع بعد 3 أشهر هذا تقصير. وبالتالي في مصطلحات، كل مصطلح لما بدنا نحكي عن المسؤولية الطبية له تعريف، وفي صعوبة في ممكن يصير حوادث، ممكن يصير يعني كل مصطلح له تعريف، وأنا من وحي ما أنت قلت الإهمال والتقصير وقلة الاحتراز هي كلها مصطلحات موجودة في القواعد.
Thank you very much. Dr. Moul Hadidi is our leading man in this medical issues. Any questions or comments? Our international audience are waiting also to participate, so local audience here.
Okay, Dr. Sbeih, can you hear me okay?
It is that we have finished within 1 hour.
Yes.
In fact, we have exactly right. Allah is
So even if the fifth nerve is violated, it's not end of the world. Actually, it can be repaired. I don't say easily, but it can be repaired. We usually transpose muscles from the superior rectus, even either full tendon or half tendon, so that a lot of times it can regain its function normally. But usually we wait. That's what Dr. Ibrahim elaborated. We wait 6 months after it is stable, so that we don't intervene prematurely.
So you don't want to do squint surgery and then you find that you have overdone it or underdone it. Because Doctor.
وباللغة العربية. قبل أسبوعين كان عندي عملية في المستشفى التخصصي، وفوجئت بكرسي رائع جدا. كانوا يظنون علينا في الماضي في تعديل كرسي العمليات. فقلت ما الذي حدث؟ قالوا هذا كان معدل الدكتور إبراهيم السبيح لإغرائه ليأتي، ولكننا للأسف لم نستطع أن نجتهد. شكرا لك بكل مكان لك ذكر.
Any questions? If not, we will meet next week and I will present the case of trigeminal schwannoma, dumbbell trigeminal schwannoma, and the middle fossa and the posterior fossa. Very interesting case. Thank you very much.
Okay, Dr. Sbeih.
لا بتقول هذا المرة هاي أنا بلاقي لك جوز أحسن من هذاك. بتزوج غيره. So great. Thank you.
Hi, Dr. Sbeih.
Hello.
Yes, hi, Dr. Sbeih. I'm Dr. Bennett. How are you doing
Hello.
today?
I'm fine. Thank you very much.
Thank you very much for an excellent presentation, a multidisciplinary. We don't see that too often. We have a few comments and questions from our audience. Wasif, I believe you had a question. Go ahead, Wasif. Unmute and ask a question.
Well, I would like to appreciate that it was a very nice presentation by Dr.
Can you speak loudly because I cannot hear?
Louder, please.
Well, I would like to appreciate that it was a very nice presentation by Dr. Ibrahim. Can you hear me?
Yes, I can. Thank you very much.
It was a very rare case. Definitely, we don't see it most often in our country. And it was a very good one. The differentials were very well explained, and definitely it was a huge list of differentials that you were depicting in these regions. And I really appreciate that you would be definitely going on with the trigeminals and other forms of schwannomas. And it's a good experience for me. So I would like to appreciate this. Thank you very much.
Thank you very much indeed.
Okay, where are you from, Wasif?
I'm from Pakistan. I'm a resident neurosurgeon.
Very good. Very good. Okay, Khalif, do you have a question or comment for Dr. Sbeih?
Yeah, assalamu alaikum, Dr. Ibrahim. Shukran. My name is Dr. Khalif from Nairobi, Kenya. Thank you for the good presentation. I've learned a lot. Just one suggestion. I don't know how we can, when you are pointing on the structures, we were not able to see because I'm sure you are pointing on a big screen.
Sure, I understand. Okay, this is a very good point. I will correct next time, and I will use the pointer of the computer to point the instructions.
Okay, we can work on that. Stuart, do you have a question, and do you want to meet Dr. Sbeih? Stuart, can you unmute, please? Hello, Stuart, are you there? Okay, any other questions or comments for Dr. Sbeih? Oh, there you go. Go ahead, Stuart, go ahead.
Good morning here in Ecuador. Doctor, thank you for your conference, great conference every Wednesday. Just one question. How, in the case of your section of the seminar, how do you manage it? How long for the second surgery in case of section of the seminal nerve?
Sorry, I did not get the question because the voice was low. Can you repeat?
Try again, Stuart.
In case of the section of the 7 nerves of surgical, in case of cerebral angle contains tumors,
Yes.
sometimes the 7 nerve is sectioned. How management it in
Yes.
this?
So your question is about when the 7th nerve is damaged during cerebellopontine ankle surgery, what one should do. Actually, the first thing is prevention. If you try to prevent that, because facial nerve function is extremely important, especially for people with professions like a banker or a lady or whatever. So this is very important. Even for an ordinary person, facial appearance is important. So try to preserve the nerve as much as you can. And that's by mastering your surgery. And you cannot master your surgery unless you are well trained. I mean that you attended lots and lots of cadaveric sessions, cadaveric lab sessions. So you take your practice into higher level by mastering it, by using the cranial nerve monitoring during surgery. But if, like in giant vestibular schwannomas, you cannot preserve the facial nerve because you cannot see it. Even in the best of hands, in the giant vestibular schwannoma, you have almost 80% risk of facial nerve damage. So you have the choices of either suturing it end to end, or putting some glue on it, or do some hyperanimation afterwards, or do some cosmetic surgery afterwards. But always wait for some recovery of the facial nerve function. Sometimes they are bilaterally supplied, and you'll be amazed at some cases where the nerve was sectioned, that they still have a very good facial function. So give a patient a time. But in the interim period, do some tarsorrhaphy to protect the eye from damage.
Thank you, Dr. Ibrahim.
You know, Dr. Sbeih, you're proud of Jordan. Stuart is in Peru. Excuse me, Ecuador. He's very proud of his country too.
We should be proud of our countries, yes.
Yeah, he's as the Andes in the background there.
I know, yes.
Okay, Adnan, do you have any comments or questions for Dr. Ibrahim Sbeih? Go ahead, Adnan, unmute. Unmute, Sbeih, please. Adnan, you need to unmute. Okay, go ahead.
You can hear me? Yeah.
Yes, I can.
For being late, I could not attend the whole lecture, but I got some points here, and I hope we'll find some video lecture or there if there is any recording of that lecture to understand completely.
Yes,
And,
there is. I think, John, you agree that this is recorded and people can go back to it.
Yes.
Okay, then I will be able to listen once again. Okay, thanks. Because there was issue of timetable, so I could not attend on the proper time. There was Jordan time, and I understood that it was 1 hour late, so I started late. Okay. Well, thanks for providing this forum. I think it's very good for us being very junior residents. But with the passage of time, we will understand, we will learn from that. Giants of neurosurgery like you, like Louis Borba and other fellows here. Thanks a lot.
Thank you very much. Next week, we will present the trigeminal schwannoma, which is occupying middle fossa and posterior fossa. So you'll need a lot of anatomy of the foramen ovale, foramen rotundum, how to open the sphero-orbital fissure, how to preserve the petrous carotid artery, and how to achieve radical excision of these formidable lesions.
Okay, all these multidisciplinary grand rounds are on the Jordan channel. I'll send links to everyone. So I'd like to thank you, Dr. Sbeih, and we'll see you next week.
Thank you very much. See you next week.
Okay, bye-bye.
Bye-bye.
Bye.
Okay.